Hello and welcome to Past Tests MRCP Part 2 Dermatology Questions. I'm Dr. Virginia Hubbard. I'm a consultant dermatologist at Homerton University Hospital London and a clinical senior lecturer at Barts and the London School of Medicine and Dentistry. So here's the first question. A 35-year-old woman presents to the dermatology clinic. She has had problems with an erythematous rash which appears in a malar distribution on her face, and severe scarring alopecia. Her GP has tried various treatment options, including a course of doxycycline, over the past year, but she has lost faith in him and wants a specialist opinion. Her only medication history of note is the combined oral contraceptive pill. On examination, her blood pressure is 124/72. She has an erythematous rash affecting her nose and part of her cheeks. She has severe scarring with thickening of the skin and scaling, leading to a large area of alopecia over her scalp. Here are her investigations. And a scalp biopsy showed immunoglobulin and complement deposition at the dermal-epidermal junction. So, which of the following is the most likely diagnosis? And I'll give you a minute or so to choose your answer. Well, the correct answer here is discoid lupus. All of these rashes that are listed in the answers are photosensitive rashes, so they all affect areas that are sun exposed. So that's typically the face, the ears, the neck, the dorsa of the hands, and if people are going barefooted, the dorsa of the feet as well. And I'll come on to why it's discoid lupus in a minute. It's not dermatomyositis though. This typically causes a rash over the face and the backs of the hands, but it will be associated with proximal muscle weakness, which this patient doesn't have. Porphyria cutanea tarda usually causes milia or small blisters over the dorsa of the hands, usually with excess hair, and that's a much more common rash that's seen in men rather than women. Rosacea does affect the cheeks and the malar region, but here you'd expect to see some pustules and telangiectasia, the hallmark of rosacea, and this patient's been given doxycycline, which usually has some benefit on rosacea. And finally, it's not systemic lupus erythematosus, because this patient has a normal autoimmune profile. So the right answer here is discoid lupus erythematosus. And in discoid lupus, there is typically scarring of the skin with erythematous plaques, as you can see here. And on the picture on the right of this patient's ear, you can see the classical scaly red plaques that affect sun-exposed areas. Patients may also have similar lesions on other areas of the face and the scalp and the dorsa of the hands. And in the other picture here of this patient's scalp, you can see the typical scarring patchy alopecia. And this is scarring because the skin looks abnormal. You can see here that it looks faintly red with a tiny bit of overlying scale. And this makes it different from a non-scarring alopecia. The fact that the patient in this question had scarring alopecia really must make you think of discoid lupus, because the only other cause of scarring alopecia that may come up in MRCP Part 2 exams is lichen planopilaris. So what are the investigations that you might want to do with a patient for discoid lupus? Well, an autoimmune screen, including an ANA, is usually negative, as in the question here. And histology of a skin biopsy will show IgG and complement at the dermo-epidermal junction. Again, this was the picture in this question. And the treatment would be with potent topical steroids, sunblock because it's photosensitive, and an antimalarial such as hydroxychloroquine. Now, one of the wrong answers was systemic lupus erythematosus, and here we have a picture of SLE. So here again we have a malar rash, but remember there is systemic involvement with these patients, which is different to discoid lupus, which just affects the skin and the scalp. And in SLE, the autoimmune screen is positive, so an ANA would be positive and double-stranded DNA would be positive. So again, that points us against this diagnosis for this patient. So on to question 2. A 78-year-old war veteran is admitted for plastic surgery for a basal cell carcinoma on the left side of his face. Past medical history of note includes hypertension, which is managed with amlodipine 10 mg daily, and atrial fibrillation without demonstrable valvular disease, although he is warfarinized. He omits his warfarin for 5 days before surgery, he is given low molecular weight heparin, and his INR is 1.3. Which of the following is the most appropriate way to manage the BCC? Have a minute or so to choose your answer. So the right answer here is excision, and the two key features of this case are that it's a basal cell carcinoma and it's on his face. And any skin cancer really should be excised, and particularly on the face, which is a relatively high risk site for a basal cell carcinoma, then it should definitely be excised. So we're not going to treat it with curettage, that's scooping or scraping of a lesion, and you'd be liable to leave some of the cancer behind and wouldn't be able to be sure histologically that you'd got the whole thing out, so that would not be an appropriate treatment. Topical 5-FU can be used in very superficial lesions in dermatology, such as an actinic keratosis, but nothing more sinister. Radiation therapy we rarely use in dermatology now. Cryotherapy is freezing, and that's appropriate for viral warts or seborrheic keratoses, but certainly not for any skin cancers. Apart from anything, you're not going to get a histological specimen with cryotherapy, and the other thing, of course, is it won't treat it. So the best answer here was excision. Okay, so what about basal cell carcinoma then? Well, as you can see here, it causes pearly nodules, classically with a rolled edge, and telangiectasia, beautifully demonstrated in this picture. And classically, for MRCP Part 2, basal cell carcinomas affect patients on the head and neck. And that's mainly because they're related to sun exposure. So they're more common in skin types 1 and 2. And by that I mean skin that rarely tans, but always burns. And the treatment of basal cell carcinomas, well, although they don't metastasize, basal cell carcinomas can spread extensively in the local area and destroy tissue. And this is particularly more important when it's on the face area, essentially around the nose. Usually, BCCs need excision with a 4 mm margin, and the histologists want to be able to see that clear margin to know that it's fully excised. With other treatments suggested in this question, the BCC is likely to recur, so excision is best. On to question 3. Consider this picture. What other condition does this elderly lady have? And make your choice now. So the right answer here is D, ulcerative colitis. Now to get this one right, you have to know the diagnosis. So let's look at the ulcer in more detail. Here we have an ulcer on a shin of an elderly lady. We can see the edge of the ulcer is irregular, and it's got a slightly violaceous hue to the surrounding skin. This is typical of an ulcer of Pyoderma gangrenosum. The edge is often described as undermined, and that literally means if you were to be able to put something under the edge of the ulcer, like an orange stick for instance, then it would go under the skin surrounding the ulcer. And typically, ulcers of Pyoderma gangrenosum are non-healing. And in dermatology, there are two main causes of ulcers that don't heal despite appropriate treatment. One of them is this, Pyoderma gangrenosum, and the other is if there's an underlying squamous cell carcinoma of the ulcer. So Pyoderma gangrenosum can sometimes be a very serious condition, as we can see in this gentleman's legs here, and sometimes it can threaten the limbs and even be life-threatening. I remember a case of one poor girl who was referred to a hospital, not where I'm working now, where she'd had one of her legs removed below the knee and another was about to be amputated by the surgeons. They had thought that she had a necrotizing fasciitis of the legs, but in fact she had a Pyoderma gangrenosum, So the treatment here was not to cut it out or even off, but to treat it properly for Pyoderma gangrenosum. So please beware any patients at risk of that. Don't cut it out. And with patients with Pyoderma gangrenosum, you really need to look for an underlying cause. 50% of the cases will be idiopathic. However, there are associations with other diseases. Inflammatory bowel disease. And in this question, that's why ulcerative colitis was the correct answer. Rheumatoid arthritis, and sometimes myeloproliferative diseases. So how do we treat Pyoderma gangrenosum? Well, firstly, with high-dose systemic steroids, so patients may need more than 60 milligrams of prednisolone in a day. And because these are high doses of prednisolone, we really need to start other immunosuppressive agents as well, such as methotrexate or azathioprine. And on to question 4. A 56-year-old lady presents with the following lesion on her shoulder, which she thinks she has had all her life. Her husband has noticed it has grown in size over the last few months. It is not itchy, nor has it ever bled. She has no other medical problems and takes no regular medications. So, what is the diagnosis? Choose your answer now. Well, I hope you got this one right, because this is a superficial spreading melanoma. And what are the features that make this the right diagnosis? Well, first clue is in the history. So her husband reported that it increased in size. The other features, which we can see on this picture here, are that it is an irregular mole with an irregular area and irregular colour. The other lesions here would not look like this. So why is it a superficial spreading melanoma and not the other diagnoses listed here? Well, a pigmented basal cell carcinoma would present as a pearly or shiny nodule, usually one colour. A dysplastic nevus would not look anywhere near this irregular. A benign lentigo is simply a freckle, so it would be one colour and it would have a regular border. And a lentigo maligna is a freckle that's going slightly wrong, so it would be mainly a tan freckle, but it may have an area within it that looks abnormal. So superficial spreading melanoma is the only answer here. So malignant melanoma, well, it's a malignant tumour of the melanocytes. And the importance is, if we diagnose it early, it saves lives, and it saves lives of young people. So it's really important that we all look out for changing moles. Here's another picture of a melanoma here. And you can see here that there's an irregular shape, irregular border, and there are 3 colours in this. And we say if there are 3 or more colours in a mole, then that's abnormal. Any size over 7 millimetres is also a risk factor. So what patients are more prone to getting malignant melanomas? Well, those with fair skin, skin types 1 and 2, patients who've had excessive sunburn and excessive sun exposure, including sunbed use, and those with a family history of melanoma. So there are 5 types of melanoma. The first, on the top right, superficial spreading malignant melanoma, and here is another picture of that. And you can see the lesion's not just irregular in shape and border and colour, but it's also large. It's more than 2 centimetres in diameter. Below this lesion, on the bottom right of the slide, we can see a nodular melanoma. So here is a deeply pigmented nodule on a pigmented lesion as its base. On the left of that, here we can see a lentigo maligna melanoma. This is the type of melanoma that's most common on faces of elderly patients who've had a huge amount of sun exposure. So have a look at this one. It looks like a tan pigmented lesion with an irregular border, but within it there's a much more deeply pigmented area. To the left of that you can see the fingertip, and this is an acral lentiginous melanoma. This type of melanoma is more common in black-skinned patients, unlike the other types of melanoma. And in fact, this was the melanoma that Bob Marley died of. And finally, on the bottom left, is an amelanotic melanoma. And again, it's a friable, bleeding nodule. And this can often catch us out, dermatologists and non-dermatologists alike. But any history of a bleeding nodule that's increasing in size really must be excised for histology. So what's the prognosis of melanoma? Well, it all depends on the thickness of the melanoma, and this is a histological measurement from the top of the mole to the bottom of the mole, and we call that the Breslow thickness. This is measured in millimetres. Less than 1 millimetre thick has a 95% chance of surviving 5 years. But if it's thicker than 4 millimetres and the surface is ulcerated, that 5-year survival drops right down to 45%. Melanoma spreads in the skin, but also via the lymph nodes. And it's really vital to diagnose these early, because early diagnosis improves prognosis. And on to question 5. A 58-year-old self-employed gentleman presents with a 4-month history of progressive dyspnea and fatigue. He complains of a painful rash on the backs of his hands, with similar skin lesions on the dorsum of his feet and on his ears. It is worsened if he goes out in the sun without adequate sun protection. And we can see the picture here. On further questioning, he has noticed a significant weight loss with reduced appetite. He takes regular analgesics for migraine. He is allergic to penicillin. He is a non-smoker and drinks alcohol socially. On examination, the following results are obtained. So, what is the most likely diagnosis? And please choose your answer now. Well, the right answer here is dermatomyositis. And let's talk about that. So, dermatomyositis gives patients a photosensitive rash, as in this question here. And it typically involves the eyelids, cheeks, and dorsa of the hands. We can see here the picture on the top right that this patient has a violaceous rash involving the eyelids and also the cheeks. And sometimes we describe this as an heliotropic rash, and here's a heliotrope from my garden. The other feature can be that there can be some associated edema. On the dorsa of the hands on the bottom left of the slide, we can see this classical feature known as Gottron's papules, and this is thickening and erythema over the intercarpal phalangeal joints. Now, patients with dermatomyositis essentially have polymyositis and a rash. So like with polymyositis, the patients have a proximal muscle weakness. And going back to this question, this man had weakness 4 out of 5 of his hip flexures. That's absolutely typical, and sometimes the patients will say that it's difficult to climb stairs or to brush their hair, and sometimes there can be associated pharyngeal weakness. Well, 30% of patients with dermatomyositis have an underlying malignancy of either the gastrointestinal tract, ovary, breast or lung most commonly. The pointers in this question that this patient may have been affected by an underlying cancer are of course his weight loss and his microcytic anemia, and possibly the crackles on his lung examination. But it's important to remember that patients can get the rash first before the malignancy is diagnosed. And how do we diagnose it? Well, the patients will have a raised muscle enzyme, or CK, again as in this case. There may be autoantibodies to striatal muscle. A muscle MRI will show inflammation, as may an EMG, and a skin biopsy will show characteristic changes. The treatment of dermatomyositis is with high-dose steroids, 60 to 100 milligrams of prednisolone daily. And then we would also add in an additional immunosuppressive agent such as azathioprine. And of course it's important to hunt for that possible malignancy and treat that. So that brings me to the end of the questions for MRCP Part 2 for PASS test. I really do wish you all the best in your forthcoming exam and hope you do very well. Bye-bye.